Thank you very much, Valentina, and thank you very much, Céliane. There were an amazing presentation on just mainly cardiac condition, and I'm sure that there will be a lot of space for discussion. And we can open a discussion, also inviting Katia and all the other delegates. And the first question was for Céliane, is about transposition of the great arteries. There's essentially two questions, all in one. And they're essentially two. So the first one is, how frequently should we monitor a fetus with complete transposition of the great artery in order to identify those at higher risk of emergency septostomy? And the other question, which essentially refers to the first one, is what is the most appropriate gestational age to identify these fetuses who will eventually require septostomy? So I think that it will be within the third trimester of pregnancy.
As late as possible.
Sorry, in your experience, do you use to scan just the day before delivery? So do you think it's easier just in the later trimesters, such as 34, 35?
It becomes more and more difficult the later the gestation is. But because you get a better idea of what's going to be happening directly postnatally, the later you look, you should try to do that. In the past, I would have done that. The situation at my hospital is now such that we do not deliver our transpositions at my hospital. And so we do our deliveries in Leiden. So the person that has the pleasure to do this is Monique Haak.
So we should ask her this question.
Yeah, we should.
And another one is for my personal interest. So you show two different parameters to identify fetuses at higher risk of pulmonary hypertension. One was based upon the velocity, and one was based upon the gestational age. So a ratio with gestational age, we should be 1. So what is better?
Ratio with gestational age?
Yeah.
For pulmonary hypertension?
Yeah, no, so sorry, it was about septostomy.
It's not gestational age. It is the entire length of the interatrial septum to the size of the foramen ovale.
Okay, so it was on gestational age. Okay,
yeah.
So I think there is Dr. Balu wants to say something.
Yeah, as Céliane said, it's very difficult to predict, despite some of the studies like pulmonary vein velocities and the anatomy of the septum regarding which fetuses eventually require the Rashkin procedure. So what we do is, because the transport is a difficult problem in many parts, especially in countries like India, huge populations and difficult roads, we make it a policy that the transpositions are all delivered as close to the cardiac center, if not the cardiac center itself. We publish this in the ISWOG journal. And only about 15% actually require a septostomy. And typically, many centers have started doing the switch procedure as early as the 3rd day or 4th day after birth. So most cases with barely open foramen ovale, we can manage with prostaglandin and then go for an early switch. But the ones who have an absolutely closed foramen ovale, we take up for the Rashkin. So whatever we do in utero, it doesn't translate exactly the same after birth. We don't know when this actually closes, and the best predictors in utero, they don't turn out to be the best predictors postnatally. That's what we have found in 100-odd transpositions which we have delivered here.
And that's exactly the reason why, even though Leiden and Amsterdam are relatively close to each other, and you can get from the one to the other in 35 minutes, we deliver our transpositions now only in Leiden.
Okay. Valentina?
Yes. I have a question for Céliane, because prenatally we try with 4D echocardiography to try to distinguish the relationship among the aorta and pulmonary artery, the spatial relationship of these predict coronary arteries anomalies. And I would like to know, considering that this abnormal origin of the coronary arteries worsen the prognosis of these babies, how good we are at predicting prenatally these abnormalities?
Well, sometimes you're lucky and you can see coronary arteries, but we don't routinely try to do that because it is extremely difficult. I also don't think that the surgeon would rely only on our prenatal images before he goes to do the arterial switch, because I think it is an enormous stress for the surgeon if he starts doing a switch and he's suddenly confronted with a coronary anatomy, which requires him to rethink his whole surgical plan. So usually what we do is if we suspect on our postnatal echo that there is abnormal anatomy of the coronary arteries, we then do a postnatal CT scan. And based on that scan, the surgeon plans his operation.
Thank you, Celiane.
Agenda, there is another question. This is just specifically for obstetrician. It regards the persistent right umbilical vein. So we know that sometimes it might be associated with fetal restriction. Sometimes it might be associated with uncontrolled flow through an absent ductus venosus, but also in cases in which there is a DV-like structure, so the baby might get restricted. So can you tell us about the type of management you adopt in terms of frequency of monitoring, timing of delivery, etc.? Just more for obstetrician, of course, and
Yes,
also
yes.
Katia and Simon.
Yeah. What we do is, but these...
And Monique, of course.
Yes, we usually monitor closely every abnormal finding that we pick up in prenatal life. As you already mentioned, the association with the FGR has been described. Therefore, we checked carefully these patients during pregnancy, but there is not a specific... if the growth is good, this is a normal variant, so there is no specific indication for changing the management for the delivery, of course. I don't know if the other people, other experts here have other opinion about that.
Well, I fully agree. I think that it really can be regarded as a normal variant. In actual fact, we didn't used to do anything special in these cases if the growth was normal.
I remember at the beginning when we started to check these fetuses, there was a literature supporting the association with PRUV and Noonan syndrome, but the problem is the association of PRUV with this extrahepatic drainage of the ductus venosus. So the risk is consistent when it's associated with anagenesis of the ductus venosus, but the problem is not the position of the umbilical artery, but the agenesis of the ductus venosus that we should take into account in these cases.
Indeed.
I think there's one study of 150 cases of a persistent right umbilical vein and its association with underlying congenital heart defects. And then there was a systematic review of the literature of 332 articles, and it included 240 cases of a persistent right umbilical vein. And if you looked at the figures on that, it had an 8% association with congenital heart defects, of which conotruncal septal defects was the highest association. So I think from our point of view of seeing a persistent right umbilical vein based on just that data, we just do a targeted assessment of the heart to ensure there's not a coexistent abnormality. And as Valentina showed very nicely, cotruncles can be very subtle, particularly with the fallows or with the malaligned VSD. So I think we just go the extra distance given that known association with congenital heart defects of an 8% risk, pretty small risk.
Yeah, and there is another question for Valentina. So what is the difference in prognosis between right aortic arch mirror image and right aortic arch with aberrant left subclavian artery?
The main difference is the association, for example, with 22q11 microdeletion has been, we published with the group of Bologna, Antonella Perolo and Gianluigi Pilu, a paper on this, and when this type of aortic arch is associated with ALSA, the risk of 22q11 microdeletion increases significantly. Therefore, yes, of course, in these cases, chromosomal microarray should be warranted in my view. But usually the problem is that sometimes we can miss the detection of this abnormal course of the artery because the problem is that you have the aortic arch and the ductal arch, and the vessels arise and course behind the ductal arch. Therefore, this could create a shadowing in the imaging. So sometimes it's difficult to detect the origin of the left subclavian artery. But the association is very, very common.
I think what's also very important when, and I think this is also extremely important, that we try to see the aberrant subclavian artery, because I've heard from colleagues, oh, well, you know, it's so difficult to see it. It doesn't really matter. I think it does matter, because if we look at our symptomatic patients and the patients that have had surgery in the first year, I can't remember one of the last period that did not have an aberrant subclavian artery. And certainly the children that go on to have symptoms have nearly almost always either a double aortic arch, which was misdiagnosed because there was an atretic segment, or they have an aberrant left subclavian artery.
Yeah, there are also a lot of questions about the use of cfDNA and genetic assessment in cases of, let's call it, isolated anomaly of the laterality of the arch. And a couple of them just says that if we have a patient who had cfDNA, which was negative also for deletions of the 22q11, so do you still recommend invasive, or just so in cases if isolated, or just carry on with pregnancy and everything is fine? So what should we tell to parents? Shall we rely on this cfDNA?
I can start to talk about that, but in my view, this involves everybody in the discussion, because
of course.
Because the problem is that I would like to underline two important concepts. The problem that we have in prenatal life, that we cannot say for sure that is isolated. For example, when I show you the results of persistent left superior vena cava, the literature underlined that in 37% of cases, anomalies appear later on in pregnancy. There is a significant portion of cases that associated anomaly appear just after birth. The problem is that we should always say apparently isolated, because we cannot say isolated. This is the main issue that we have when we manage these patients. Of course, the problem is that, for example, for ARSA, we know very well, yes, it has been described, the association with 22q11 microdeletion in isolated cases is very low. This association is consistent with trisomy 21. So if we want to rule out trisomy 21, cfDNA is the best tool that we have if we don't want to perform an invasive test. When we talk about 22q11 microdeletion, we are not there, because even if the results are improving for the detection of this anomaly by the use of cfDNA, the predictive value is low at the moment, but the problem is also the prevalence of the condition in the general population. We don't know the real prevalence of this condition in the general population. This is a matter of fact. So we don't know how good the cfDNA is at picking up this 22q11 microdeletion. So it's important to counsel the patients on this. This is my opinion. I don't know what you think.
We have looked at our cohort of right aortic arch, of which it was predominantly right aortic arch with left arterial duct. And we found an incidence of genetic abnormalities of 22% in that group. And these were really isolated lesions, because we had also controlled postnatally and had data. And there was a 5.5% of the children had 22q11 deletion. And there also was a very high incidence of trisomy 21 and several other genetic abnormalities. So we always discuss doing invasive testing when we see a right aortic arch.
Yes, this is what I reported also in my presentation. Right aortic arch, independently by the association with other anomalies, is associated with an increased risk of this condition. I completely agree. But
Monique?
it's different for ARSA, for something else.
I fully agree with you, and in my talk about genetics in the last in session 4, I also advocate to perform invasive testing, because now in the centers and in healthcare systems that can afford and can offer exome sequencing, I also encountered the last 4 or 5 years that the fetal phenotype is not complete, as you said. And secondly, I think also the knowledge about postnatal phenotypes is changing, because I think in the past fetuses that, for instance, were terminated or did not survive until surgery, those kind of heart abnormalities, they are now not described in certain genetic syndromes, and that is changing. That whole field is changing. Now we are applying exome sequencing in fetal life.
Simon.
A very quick comment. We are doing genome-wide NIPT, and we go down to 7 megabases, which I think is probably a pretty common cutoff, what many people are using in genome-wide. It'll pick up a certain proportion of 22q, but most of these will fall below a 7 megabase deletion. And Sally Ann's figures are pretty consistent with Paolo Volpe and Masha Bronstein's figure, 15% association with 22q. And yours a little bit higher, because I'm guessing it includes beyond 22q deletion. So basically agreeing with everybody else, but just giving you our local experience. So I think we're on the same page. We offer an amnio.
Yeah, and the problem is that some of these studies, actually, they did not report the actual occurrence of DiGeorge, for example, in cases in which we can see the times, because most are very generic regarding as a definition of an isolated anomaly, that just refer to the macroscopic anomaly. So I don't think that there is any robust data on the occurrence of this condition or genetic condition in cases in which they have a detailed assessment in order to identify subtle anomalies related to 22, such as times and etc. And let's see whether there are other questions.
May I ask something? Do we still agree as to the fact that transposition is the only heart anomaly where additional invasive investigation may not be strictly necessary, or we want also to revise this concept? Because what I understand from the discussion today is that we are now advising to have invasive investigation, genetic investigation in all cases of cardiac anomalies, and transposition used to be, simple transposition used to be the only exception. Do you still agree or not?
I have never encountered an abnormality in simple transposition. And if you look in the tables in literature, then in my cohort of 4,500 fetuses, we had one abnormality, but that was a clotting disorder. So you had to click the box genetic abnormality, but it was a clotting disorder inherited from one of the parents.
We found some imbalances visible only with the CMA. So nowadays we are offering always CMA when we diagnose a cardiac defect, including transposition of the great arteries, some unbalanced translocations.
And
so do we.
Simon?
We do the same thing. Yeah, we do the same thing. We offer genetic testing. I mean, your figures are pretty impressive, Sally Ann, in terms of that. I'd put that to print. But what is available in print is there is a 1 to 3% chance of a chromosomal abnormality. And then, as Valentina said, there's always that concern about a coexistent abnormality that you're not picking up. You know, we've almost reached the point in prenatal imaging that there are very few conditions that we don't offer amniocentesis for along that same argument.
The perception that we have is that we always say that transposition is not associated to aneuploidies because it's associated with something else.
Correct.
Just find out what.
Yeah.
Balu, do you want to add something? Because I know
yes. Transposition, 2 points. First is regarding genetic testing. Maybe about the experience of about 1,000 odd arterial switches performed in our center. We rarely have encountered obvious genetic phenotype. I can't say about genotype, phenotype at least in transpositions. And most of them have a good neurodevelopmental outcomes on follow-up. They pass the tests, they go to school. So basically, grossly, on a phenotypic level, they are well. Of course, there could be an argument that genotypically things can be different. If you do testing, you may find something. But the question is, if we find something, then we need to also explain the genotype-phenotype correlation as well. So generally, an isolated transposition without any other features, I reiterate that, without any other features, we don't generally offer genetic testing. The second point, which I was trying to make earlier about Sally Ann was talking about coronaries in transposition. Now, most of the surgeons are okay with most forms of coronaries except the intramural coronaries, where the coronaries run between the two arteries. That is something which will be very hard to pick up prenatally. So I think that particular aspect of imaging transposition will have to be left to the pediatric cardiologist after birth, because it will be something which we have to do. You know, most of the time the surgeon says we'll operate with your prenatal images, but I say no, intramural coronaries I can't pick up. And that can be, they manage, they have their techniques, but then I don't want to be called to the OR and said, look, you missed this. So you need a postnatal echo for all. I'm pretty clear about that.
Yeah, thank you. So there is another question about the association between left superior vena cava and coarctation of aorta. And also at the beginning, I think this is specifically for cardiologists. At the beginning, I thought that this association, which has been largely reported, was spurious, and it was due to the fact that this leads to imbalance in the four-chamber views. But the fact that several studies now, which did multivariable logistic regression analysis, actually they report that this is an independent association. So which might be the embryological basis of the association between left superior vena cava and coarctation, and how frequently is this association in your practice and in everyone's practice? This last part of the question is for all the speakers.
In our experience, is less than 50% that I found in the literature. I agree with you that we checked the papers on coarctation of the aorta. There is a very recent meta-analysis by Cecilia Villalain, and it was a protective factor in presence of disproportion. The presence of left superior vena cava is a protective factor for to justify your prenatal suspect, but it's not an association. It happened to us to find some cases, but usually in this case you have also a dimension of the aorta really smaller than the pulmonary artery, so it's not just a matter of disproportion for chamber view, but I agree 50% is too much for the association.
Yeah, and you're right, Valentina, but other papers actually report the opposite, that there is an association. Right. So I'm just asking Balu, so what is the embryological basis? Because I think that this is a question for an expert in cardiology.
Yeah, Francisco, this is the pure isolated left SVC and coarctation we rarely have found. And there has been a large meta-analysis in circulation about the various risk factors for coarctation, including left SVC, VSD, and then several factors which are specific measurements of the aorta, aortic valve, like bicuspid valve. They did not find an association between a persistent left SVC and coarctation. We haven't found. But the one thing which I always insist on a postnatal echo for left SVC is the rare variant called the unroofed coronary sinus in persistent left SVC. This can be sometimes quite difficult to pick up prenatally. When it is unroofed, the left SVC, in fact, ends up draining into the left atrium, and then it will obviously cause cyanosis. So this is, I have found it in one left SVC in my entire 15, 16 years of prenatal, practice. And in fact, that baby had a VSD also. Interestingly, what happened was the left atrial pressure was high when the VSD was open. And when the surgeon closed, the left atrial pressure came down, because the shunt came down and the left SVC started to manifest. So it's so important that at every stage, the roof of the coronary sinus is looked into in a persistent left SVC and make sure that it is roofed. And that's something, the only clinical thing which I have found important in left SVC apart, but no association with coact to the best of my knowledge and experience.
Simon?
Just a very quick comment to make, because there's a very broad audience listening to us today in the setting, just reinforcing what Valentina had said in her talk. In the sense of seeing a persistent left superior vena cava, it's strongly associated with a coexistent cardiac abnormality. And I think if you look across all the studies that have been published to date on the topic, is once you see a persistent left SVC, involve a pediatric cardiologist, and that's our rule of thumb. And I think the most convincing series is from Paris, from a single center, of where they had about 260 or thereabouts of persistent left SVCs. And you were more likely to have a coexistent cardiac abnormality than not. And that's an important take-home message. Get a pediatric cardiologist involved when you see it.
Yeah, obviously. Thank you so much, Simon, and thank you so much to all of you. And we are actually came to the end of this session. And now you have, if I remember well, 15 minutes break, and then we are looking forward to have you for the last session of this course. See you in 15 minutes.